So here we are going to discuss each step of the silk procedure in detail. First step is the 0-180 axis marking. Here we are using a bubble marker. Anyone can use a slit lamp machine also for the marking. After the marking is done, patient is shifted for the procedure. This is the interface of the machine, which is quite simple and intuitive and makes the treatment planning very easy. Here we are planning a -2.75 sphere with 0.5 cylinder. A nomogram adjustment has been done. It also gives you the complete picture of the biconvex lenticule, the thickness of the lenticule, residual bed thickness, the side cut, the diameter of the lenticule, and the estimated time of the surgery. Now we install the applanation cone and scan the PI. System checks for any tilt or variation in the cone glass. This is a very important step as this will account for any variation in the glass and can ultimately affect the result or the dissection of the surgery. We can use the joystick to adjust the machine, and this is the second part of the PI, the suction ring, which is being placed on the eye. It is connected to the system port from where it generates the vacuum. The suction ring here is used to fixate on the eye, and once the centration is fine, the vacuum is instantly achieved. Now you use the joystick to lower down the applanation cone onto the ring. Once the cone fixes onto the ring, you check for the optic position indicator on the right side as it comes on the green zone. Somewhere in the middle, not very low, not very high. Now you pinch the suction ring and the cone applanates the cornea. The meniscus should go beyond 10 mm to give you a wider area for adjustment. Now you lock in this position and go for the centration and the cyclotorsion adjustment. It has got a very good touchscreen mode, so you can do it by yourself. Now the laser treatment is started by moving a raster scan line in a radial pattern. It resects the posterior surface of the lenticule first, then the side cut, and then the anterior surface of the lenticule is cut. At last it creates the cap cut, and within seconds the treatment is completed. Now you undock the patient and shift it under the microscope. Here we are using a separate microscope. The microscope from the examiner machine can also be used. Wetting the surface improves the visibility a lot. Then we enter the gap. Try to find the anterior and the posterior plane. This is the tricky part. If you find the anterior and the posterior plane, your surgery becomes quite easy. So the trick here is to tent up a dissector a bit and enter the anterior plane, and while entering the posterior plane, dip in a little because it's a biconvex lenticule. When you enter the posterior side of the plane, you will see that due to the opaque bubble layer, the clarity is slightly reduced, and when you are entering the anterior surface, the clarity of the instrument is quite good. In a windshield wiper manner, you dissect the complete lenticule till the edges. Then you try to enter the posterior plane, and in the similar windshield wiper manner, the posterior lenticule part is also cut. You may find little resistance at the 3 o'clock and the 9 o'clock position, as it helps in preventing the rolling over of the lenticule. Once we are sure that the lenticule is completely dissected, with the help of a forceps, we grip the lenticule and pull it out. Just check for the complete integrity of the lenticule, and At the end, we just iron the surface of the bed so that the post-operative recovery is quite fast. This interface OBL clears up within minutes and you get a very good visual recovery by 24 hours.